One of today's biggest challenges are patients' echo exams that are non-diagnostic. That's why I'm excited to share a new way to elevate your diagnostic confidence and efficiency. GE's next-generation imaging architecture, C-Sound, created specifically for cardiovascular ultrasound.
Hi, I'm Dave Fornell, the editor of Diagnostic and Interventional Cardiology magazine, and I'm here in Chicago at the Transcatheter Valve Technology Summit with Cardiovascular Research Foundation. I have with me Juan Granada. He's the Executive Director and Chief Medical Officer with the Skirball Center of Innovation, which is a CRF organization, and I wanted to talk to you a little bit about the evolution of TAVR technology.
Thank you, Dave, for the invitation. I mean, it's amazing to see how far we have come with TAVR. You know, in this meeting, as you may have seen, we're presenting now long-term durability data. We're now presenting what it was emerging TAVR systems now entering into big registries and big clinical studies. And it's amazing to see the live cases with now second and third generation valve technologies, you know, how controllable, reproducible, and clinically successful these devices have become. So, I mean, really, this is a transformational technology.
From the first generation to the second, third generations that are now in use, I was listening to some data from Marty Land this morning that stroke rates and other complications have gone on astronomically to where it's either on par or better than surgery.
That's the classic combination of learning curve, clinical adaptability, and smart engineers. You know, as you may have actually observed, with the first generation TAVR devices are getting smaller. They're getting actually more deliverable. Sheets actually getting smaller as well, and actually more flexible to get to the place that we want to. Now we're using distal protection devices or cerebral protection devices. We have better imaging understanding, which is actually key for the success of this technology. So, I mean, like it happened right now with drug-eluting stents. We're going to get to the point in which these type of complications that we saw 5 years ago will be pretty much below 1% in every single type of parameter. So this is an amazing evolution over time in such a short period, because we're talking about maybe 5 years since the big trials.
I remember sitting in a TCT where they were just discussing in concept or in trials in the second, third world about implementation of these devices, and here they are. There's an entire conference built around them.
Exactly right.
The technology has gotten pretty good, and if I remember the statistics, there's somewhere close to 500 centers now in the United States, and a similar number in Europe that are now doing TAVR procedures. And it does require special training, it does require special tools, it requires a heart team approach. But at this conference, one of the discussions is, do we need the heart team, and do we need TE imaging, and can we do this as a same-day procedure?
Listen, there is a big difference between U.S. clinical practices and out of the U.S. clinical practices for many reasons. A lot of these practices are based on reimbursement. They're based on how good you work with the surgeons. I mean, you cannot really force the entire world to work with the surgeons, because it's on a case-by-case type of approach. But in general, if you actually look what has happened with the introduction of TAVR, is there is now a better understanding of the specific roles of every single operator in the cath lab. There is a full-blown integration of imaging into the cath lab. I mean, right now, you cannot really start this program if you don't have a superstar in imaging. The surgeons are actually now more open for collaboration with us in terms of vascular access and deployment. They want to learn actually catheter-based procedures. So in a way that I see it is, do you really need to form a heart team? I really don't really think is necessary. You really need to have the right team, and the right team has to include a surgeon, because I mean, vascular complications will occur, and actually valve complications will occur. So the surgeon has to be part of this. If he's always part of the procedure, it all depends on how the dynamics of the team actually are. You really need a very strong imaging component, and you really need a strong actually anesthesia component. Now, how do you do it and what is the best practice to do it, I think it needs to be determined, and I don't really think there is a right or wrong way to do it.
Yeah, with the imaging component you're referring to, both the CTA.
You really need a strong CTA group to help you to plan the procedure, and you really need a very strong imaging person helping you out. That is actually a controversial subject, as I know my European colleagues say, well, we can do it only based on X-ray and just kind of not really intense imaging. From our point of view, and I'm speaking most of my Columbia colleagues, they would agree that having a very well-trained, superb superstar with you doing these procedures makes your life way easier. And I think the outcomes will be better because you can really avoid complications by doing this.
And then during the procedure itself, having a TEE echocardiographer right there in the lab with you.
That's actually where, I would say I don't really think it's controversy. It actually comes down to cost, operational aspects, and how useful it is. I mean, listen, it comes down to the use of endovascular tools for coronary procedures. I mean, is that mandatory? No, but I mean, if you're going to do a left main procedure, you better have IVUS and all the tools that you can actually have to plan and perform the procedure better. And no question that actually having, a good TEE person working with you makes the procedure much safer, and the deployment of the valve much better.
And then coming down the pike in the next couple of years, what are some of the new technologies that'll work in union or conjunction with TAVR?
It's like, you see, like a stents, all right? I mean, we started with first generation devices. Now we went into a war for stroke thickness, and I think it's going to be the same with TAVR systems. It's going to be about profile. It's going to be about deliverability. It's going to be about easy to use. I mean, to your point, we may get to the point in which the procedure is such an easy procedure with a small profile device that we may say, well, I think now this is the right time to not get rid of the transesophageal echo, but maybe just use it on cases that are complex, maybe simple cases we don't need it. And I think it's going to come down to technology iterations. Then we'll go into the durability issue, because we said, okay, now can we put this valve in lower risk patients, but now we need 10, 20 years durability, and can we achieve that? And I think the 20 years ahead of us will be more of biomedical engineering, improvements on leaflet durability, new leaflets, new materials for the frame and for the leaflets as well.
Well, thank you very much for your time today.
Thank you for the invitation.